And I am Caroline Gooden, and I'm going to share my screen and get us started. This is pretty fancy stuff. Brandon's teaching me. And as we wait for it to come up, if you would please put your name and email in the chat and anything else you'd like to share about yourself. So are you seeing my fancy display now? All right, so here we go. We are delighted to have you all with us for our first session of this spring Scope series. We have an awesome session for you today. I am Caroline Gooden, Project Director for Kentucky Scope. Other members of our team, and we are definitely a team effort, which includes all of you on this call. Juliet Souders is here. She coordinates all of our facilitators. Brandon Canada handles all our technology. Michaela Roark does our evaluation, and she will jump on towards the end. All of our facilitators are here. Juliet will introduce them to you briefly, and we appreciate all of you who are participating today. Glad to have you all. So just a brief rundown of what's coming up for this series. We have some really exciting sessions for you. We are thrilled to have Dr. Catherine Marks to talk with us today about Kentucky's response to the opioid crisis. She's going to really set the scene for what we're talking about in this series. In 2 weeks, Amanda Metcalf and Morgan Eversole are going to share for us their perspective as peer support specialists and how important that is for families in recovery. March 10th, Carol Cecil and Barb Green are going to talk with us about family provider partnerships. They live, work, and breathe that, and they're a great presentation duo. On March 24th, Miriam Silman from the Department for Behavioral Health will talk to us about how systems-enabled trauma for families with substance use disorder. And then on April 7th, we are excited to have Letcher District Judge Kevin Mullins, who's going to talk to us about the family court process. April 21st, Kristen Dahl will talk to us about self-compassion for ourselves as providers. May 5th, Ginny Sprang from the Kentucky Center on Trauma and Children will talk about strategies for us for resilience. And lastly, on May 19th, we'll close out with Dr. David Lohr, who is from the Department for the DCBS, Department for Community-Based Services. And he will talk to us about toward an understanding of recovery for persons with addiction. So a great selection of topics and speakers for you this spring. Julia, do you want to tell us about our facilitators for this day?
Yeah, I'd be happy to. So we have some moving parts with facilitators. So the ones that are available today are Melissa Hampton, who is a child development director with Cardinal Hill with a background in early childhood education. Kayla Harmon, who is a family peer support specialist at Kentucky Partnership for Families and Children. We have Dr. Andrea Whitwer, who is visiting us from Ohio Scope, so we're excited to have her. We have Karen Cottingham, who is an early childhood consultant at North Key Community Care and works with families and children who are substance exposed to help them gain skills to thrive. We have Tanya Torp, who directs Step by Step, which is a program for young mothers. She's also a community organizer and a pastor and a LEND trainee. Myself, I am a program assistant at HDI, and I have a background in human development, psychology, and sociology. Dr. Caroline Gooden, who is the project director for Scope and LEND, and also has a doctorate in early childhood. We have Bridget Talley, who is a heal recovery coach at Voices of Hope. We have Sasha Braven, who is studying public health at UK. We have Austin Nugent, who is a disability and health program coordinator at HDI, and she has a background in sociology and disability studies and is working on her Master's of Public Administration and Disability Policy. We have Dr. Bundy, who is a psychologist and board certified behavior analyst. We also have Michaela Saylor, who is a clinical psychology doctoral student at Eastern Kentucky University And we also have Gabby Martin, who is a psychology doctoral student at Eastern Kentucky University and also a LEND trainee here at HDI. So we're so grateful for all of our facilitators, and where you'll get to meet all of them more in your small groups and hear more about them. And we're also so excited to hear more about all of you, our participants.
Thanks, Juliet. So this is what our schedule looks like for today, more or less. We're going over some of the call procedures, and then we will turn it over to Dr. Marks, who will talk to us about Kentucky's response to the opioid crisis for about half an hour or so. And then we will have, depending on how our timing goes, we'll have about probably 20 minutes or so for small group discussions. We have questions that you all will talk about, as we've said ahead of time. And then we'll come back together at the last 15 minutes of our hour and a half together to share together what we talked about in our small groups and to wrap up for today. Just a few reminders about how these Zoom calls will work. Please keep your cameras on while you're on the call. And when you're in your small breakout groups, please unmute and share equally. Sometimes we will talk about sensitive topics, and we encourage you to take care of your own needs during these discussions. Sometimes things will get very tender, and we encourage you to do what you need to take care of yourself. We also appreciate everyone protecting the confidentiality of the customers that we work with, and we change the names of all persons who we discuss. We encourage you to actively engage. This is a fun kind of training series where we really are actively talking together, problem solving together, and talking about strategies that we'll use for children who've been exposed to substances and their families. We will use person-first language, such as we'll talk about a child who was born substance exposed. Our sessions are recorded and closed captioned. You can turn on the captioning on your Zoom account there. Feel free to ask questions at any point in the chat, and I will relay them to Dr. Marks as she's speaking. And we ask that we all respect everyone's viewpoints. Everyone has equal say here and equal weight in the discussion. Lastly, just a reminder that addiction, which underlies everything that we'll talk about this series, addiction is a disease, not a choice. We will start on time and end on time to be considerate of your time. And we encourage you to send case studies based on your clients who you work with. Please send us case studies on any of the topics that we talked about that are coming up. Send them to Juliet or to me. If your case study is selected for discussion, you will have several really good book selections to pick from as an incentive. So we appreciate your participation that way. Some of the terms that you'll hear Dr. Marks use today, and you'll hear us use throughout the series: substance use disorder, you'll see it abbreviated as SUD. It affects both brain and behavior, leads to the inability to control use of substances such as legal or illegal drugs, alcohol, and medications. Substance can range from moderate to severe. You'll also hear us talk about opioid use disorder, abbreviated as OUD. We'll also talk about neonatal abstinence syndrome, abbreviated as NAS, which is an infant's response to withdrawal of substances that they were exposed to before birth. And lastly, you'll see mention today of our area development districts in Kentucky. There are 15 geographical regions in Kentucky that are called the AD districts. Brandon, you want to cover this one?
Yes, sorry, we just got a new registrant, and I was trying to share the link in case they wanted to join right now. Hey guys, I'm Brandon. Thank you for being here. Take note of a couple of these links on this screen. You've probably seen these in some of the email correspondence, but it's going to be the same Zoom link for each of our 8 sessions. So that should be a constant. And also this website here where we post the presentation slides, other resources, CEU information. If you have any questions about accessing that or how to get to that and navigate to it, shoot me an email or any kind of message, and I'll be happy to help you out with that. And this is also where we will post recordings of the session after the fact, if you ever need to go back and reference what we talked about prior. But thanks for being here.
Thanks, Brandon. And I encourage you all to check the resource site. Even before our next session, there's a couple of trainings that are coming up between now and February 24th. So check back often to that resource site to see some exciting trainings that are coming up. I am now delighted to introduce Dr. Marks. Dr. Marks is really well qualified to open the series for us and to talk about the state of the opioid crisis in Kentucky. She is project director of Kentucky's opioid response effort, also known as CORE, K-O-R-E. She's also assistant professor in the UK College of Medicine. She has many projects that she directs. Some of them include Kentucky's Communities and Networks Helping End Addiction Long-Term, or Kentucky Can Heal. Probably many of you have heard about the HEAL projects in Kentucky. She also leads Kentucky State Opioid Response Grants and Kentucky Women's Justice Community Opioid Innovation Networks, among many others. Dr. Marks is well published and presents in this area across the country, and we are thrilled to have her with us today. I'm going to stop sharing so that Dr. Marks can take it over.
Thank you so much, Caroline. I really appreciate that introduction. I heard as I was listening to introductions, a number of people working on intersecting projects. And so it's always great to see that overlap. I heard someone with the Healing Community Study, which is wonderful, and many individuals working in partner sites. So thank you first and foremost for the work you are doing in this space. It's so important. So let's get started here. I've got some slides for you, but I just want to encourage you to ask questions. Caroline's going to help me navigate both questions in the chat, or don't hesitate to just cut me off and ask something. I enjoy discussion in this space. So my goal is kind of twofold for this kickoff. One is to describe the key components of a comprehensive response to the opioid crisis and talk about the services and supports that CORE funds. CORE is just one part of a huge system. And so this is not a comprehensive list of everything that's happening in the opioid space, but what is going on with your state partners, at least, which is always helpful to know. I hope that I will convey a sense of urgency in the need to do this work, but also a sense of hope that that we have evidence-based practices, that we know that people do enter remission and recovery, and that communities as a whole can heal. And I also want to make sure that I acknowledge the complexity. We know that there is multifactorial in the causes, and the solutions similarly are complex. And so sometimes we want to try to boil it down, and I hope that it just feels a little messy for you at the end, because that's the reality. All right, fancy graphics. I promise I won't have many fancy graphics there. So let me start with just an overview of CORE and our statement of purpose. So we are guided by a recovery-oriented system of care framework, and the purpose of CORE is to implement a comprehensive targeted response to Kentucky's opioid crisis by increasing access to really the full continuum of evidence-based opioid prevention, treatment, and recovery support services. So we attempt to really expand infrastructure in all spaces, and I hope to demonstrate a couple of those for you today. Just as kind of a little orientation to what we mean when we say kind of state health authority or the cabinet. So CORE, you are here, is in the Department for Behavioral Health, Developmental, and Intellectual Disabilities, which is classified by SAMHSA as the single state agency or behavioral health authority. And so we receive federal dollars that come from SAMHSA to help with behavioral health safety net type issues. We are housed within the Cabinet for Health and Family Services. It's really actually pretty neat. In Kentucky, we have a very comprehensive health and family services cabinet that includes public health, Medicaid, community-based services, and Inspector General's office, which means a lot of the agencies that need to work closely together have the opportunity to do so. But we partner really closely with a lot of different entities. The governor's office, of course, Justice and Public Safety, where we have the Office of Drug Control Policy, the Department of Corrections, Public Advocacy, our courts, and our universities. I can't underscore how important the state university partnerships are, both for training and education, for implementation science, for research, for developing our workforce. It's just such a vital connection. And of course, things like Healing Community Study, or this project is a perfect example. And then just numerous community partners. CORE itself has about 400 different sites across the state that are active in the opioid response. So, okay, we're going to start big. We're going to start at the national level and then zoom into Kentucky. And so this is CDC provisional overdose data. And I pulled this data down for us just a few days ago. And what it's showing is the percent change. I'm going to read it, but then I'll explain it. The percent change in predicted 12-month ending count of overdose deaths. And so what this is telling us is how have overdose death rates changed from last year to now. So from June 20 to June 21, what's the difference? And what we see is that statewide, or sorry, nationally, as we all know, this is increasingly getting worse. There was a 20.6% increase in overdose deaths nationally. Unfortunately, in Kentucky, it was far worse. We saw a 35% increase. And as you see from the change in the color scale, Kentucky is clearly one of the hardest hit states. This is not breaking news for anyone, but a constant reminder of the work ahead of us. We just also received the kind of national data for the rankings of 2020 of states' rates of overdose death, and Kentucky is now second highest with overdose death rates, which is really, it's just tragic. Knowing the work that's being done, knowing how hard people are fighting to stay alive, dealing with kind of the influx of fentanyl that's come in the state, it's just, we've got a long way to go. I want to flag for you also that this data is accessible to you, and I want to say this a couple times throughout. So this is publicly available. If you, the easiest way is Google CDC provisional overdose data. And this is basically one of the first websites that'll pop up for you. And you can scroll over any state and see this data. And it's updated monthly with obviously a time lag for reconciling the data. So then when we start to look at Kentucky specifically, what I wanted folks to be able to see here is which counties are most impacted, but also importantly, how the impact has changed and moved across our state over the past 4 years. Imagine we'll have 2021 data probably available in the middle of this year. What the original kind of story, and original is not a fair term, I'll say in 2017, when core funding came, we focused very heavily on the impact in our large urban areas, Louisville, Lexington, Northern Kentucky, and then Eastern Kentucky kind of categorically. And what we see over time, although this maps all acknowledge aren't the best at showing it, is that the impact, the hardest hit areas have really shifted from true Eastern Kentucky more up to Central Kentucky. And there's a lot of kind of thought behind or wondering about what the rationale for this is. Some people think about the interstates and how they affect drug trafficking. They think about how there was a ton of grassroots efforts that were launched in Eastern Kentucky to address this. Not that Eastern Kentucky has solved this by any stretch. And so I don't think we fully understand it, but we do know it is certainly shifting in its focus. Some other folks might talk about also prescription opioids versus heroin versus fentanyl and changes in the patterns in drug use across regions of the state. So I also wanted to show you this map mostly to flag for you that this is also available for you to access really easily. So thanks to our wonderful partners at KIPRIC, the Kentucky Injury Prevention Research Center, they have recently launched a overdose mortality dashboard that is available to the community. And so when you log on to KIPRIC's website, and I believe I embedded the link in the PowerPoint slides that you have or will receive, it allows you to go in and indicate the year, the category. There's several drop downs and indicators. And you can really get very local data to drive your own decision making. I think this is so important for local decision making, for helping to influence local policy and regulation discussions. And also when you're writing a grant, you need to quickly be able to make that justification. This resource is just going to be a game changer in folks' ability to access their own data. We spent a lot of time talking about the opioid crisis in terms of raw numbers. We have got to expand our narrative to talk about subpopulations within Kentucky and how they are impacted. And so historically, white Kentuckians, as it was nationally, had a higher rate of overdose death than Black Kentuckians. That is no longer the case, and this trend is alarming and has really required us to double down on our efforts, evaluate how we have failed to reach our Black Kentuckians and what types of systemic racism has created this kind of skyrocketing trajectory of Black Kentuckians in their vulnerability to overdose and overdose death. And so this data is reflecting 2017 to 2020 and is summarized at the bottom, which shows that from 2019 to 2020, there was a 49% increase in overdose death among white Kentuckians, but a 64% increase among Black Kentuckians. And so that rate is really important. Raw numbers aside, because rate is really all that matters in this case, we have got to change our strategies to think about equity and cultural competence and inclusion in all of our activities. And one of the things that the cabinet has done is to adopt anti-racism principles that we are working to instill throughout the grant, throughout our department and cabinet. And this is an ongoing work for us. We also participated in the National Governors Association collaborative around this, but I would really encourage the discussion of race and all that's being done here as well. We also need to break this out by age, and I could go on. We need to break it out by sex and socioeconomics. I don't have all of those for you today, but I think it is helpful to understand trends in the data in terms of age groups. Sometimes people just assume overdoses occur highest in our younger population, so maybe the 25 to 34 or 15 to 24, but the reality is that for a long time, 35 to 44-year-old individuals were the group with the highest rate of overdose death. And again, I'll thank KIPRIC for developing this data very recently for us. Historically, the second highest group had been individuals who were 45 to 54 years old, but we've actually seen a change. We're now seeing a younger population more affected. So our 25 to 34-year-olds are seeing, you see that in 2019 to 2020, massive gap. But we have to think about the full continuum. 55 to 64-year-olds, their rate is as high as 25 to 34-year-olds in 2020. And so thinking about our interventions across the lifespan, making sure that we don't that we include our Medicare population when we're thinking about policy and access to services. This is just, it's so important. All right, and then this is, I imagine this group has seen this data, but this is the NAS rate by ad district of residence in 2019. And so this shows you NAS rates, again, by region. I know that 2020 data is drafted and ready to go out. And I did get to a sneak peek at that. And it's interesting to see some of the changes. Certainly there's increased rates. There's other regions that we're seeing it go down in. So that's exciting. multifactorial in why that's occurring, and certainly interactions with COVID could make that complicated, but we certainly need to monitor our NAS rates. Clearly Eastern Kentucky focused on this map. All right, so I am going to transition a little to strategy and thinking about frameworks for responding to the opioid crisis in general. And what I like to start with is really some guiding principles of service expansion. And for us, those are, we call them the AAAQs. It just doesn't really roll off the tongue. But what we're looking for is expanding services in a way that they are available statewide, that they are accessible and equitable, accessible without discrimination, that they are person-centered and culturally appropriate, and that they are quality and evidence-based. This is actually drawn from the World Health Organization's right to clean water ethics, and has been adapted for a couple different public health campaigns. There are many other ways to organize this, but this one has been helpful for us. So thinking about expansion across those domains, we then think about a cascade of care framework for responding to the opioid crisis. And this is really focused at the individual level. So we can think about kind of a continuum of experiences for individuals where we want to start by attempting to prevent the initiation of use for those maybe that need to be prescribed a non-opioid medication, or we want to work on building resilience and coping rather than starting to misuse substances. We then, if we do transition to misuse, attempt to intervene to prevent the misuse, and then you can kind of see how it goes. Our next step is to identify treatment need early through things like screening and brief intervention. For those individuals that do screen positive and are assessed, we've got to provide treatment access and engagement. So increasing treatment access, really engaging people. We've learned so much through COVID what it means to literally meet people where they're at, which means we can't sit in our offices or in our clinics anymore and wait for them to come in. They might not come in. And so providing that true access, we used to say, we want a no wrong door approach to treatment. And then one day I was like, why do we have doors? Why are we in buildings still? Let's get out there. Let's get out on the streets. I could do a whole other hour on mobile services. And then once we get individuals into treatment, we've got to retain them in treatment. This is the stuff that's sometimes the most challenging, right? And overlooked in measuring our metrics. And so retaining people as long as we can. Gosh, we use 6 months as kind of a minimum benchmark, but pushing it as far as we can go. And then sustaining that remission and recovery kind of completes the cycle and really becomes prevention again at that point. Two really key principles here, though. The first is that you'll notice that harm reduction isn't a single hexagon in this continuum. Harm reduction should occur throughout the duration. So we might need to reduce harm when an individual is beginning to experiment with a substance. We need to provide harm reduction to individuals who are in active use, and we need to continue to prevent future harms, even for individuals in remission and recovery. That might look like still providing them a naloxone kit, because we know that they could still be at risk. And if they're not, they might be around someone else that is. And so understanding that harm reduction is not a single stage is so important in our response. And then, of course, building personal, family, and community capital across this continuum is vital. All right. So we have to think of it one more way, though, right? I wouldn't be an academic if I didn't present just a third framework just to flesh it out. But thinking about things in ecosystems, I think, is important. And we talk about a biopsychosocial model. This is another way of thinking about it. We have to address kind of the individual and intrapersonal level. And that's where we talk about ideas of recovery capital or general capital. But then we also have to intervene and support the community levels, employment, education, housing, reentry support, peers. Our institutional levels have to be addressed: housing, medical services, vocational and education, and of course, policy. My passion at this point, creating that policy infrastructure that allows all of these other levels to provide the support they need. So with that, I'm going to kind of take my third pivot and spend some time talking about CORE specifically, what we're doing, what activities are out there, and maybe some resources that you would be interested in accessing or connecting your folks to, or thinking, we need to start that up where we are. So first, we have 5 priority populations. This is based on the data that says that these individuals are either at most risk or that they are really part of what it's going to take to kind of comprehensively right the ship. So of course, individuals who have experienced an overdose, the data is clear. Those individuals are most likely to experience another overdose in the future. So we've got to work and reach out and find those folks. Pregnant and parenting persons with opioid use disorder, of course, that's why we're here today in part. Individuals who are justice involved, and then kind of expanding out children, youth, and families impacted by opioid use disorder. We recognize that not only preventing that next generation, but creating an environment where people can recover with their family is just, it's pivotal at the individual level. And then co-occurring mental health and opioid use disorder is critical. We really lack the infrastructure to treat true co-occurring disorders, and they are so prevalent, we know that. So core programs, let's see. Here's just a high level view of what we're up to. This is fiscal year 21, so I'm talking about the number of persons served between from October of 2019 to September of 2021. It took me a long time to get my fiscal years down for the federal level, but 14,000 individuals unduplicated received opioid use disorder treatment services through these grant-funded programs. Another 9,500 received recovery support services. 53,000 free naloxone units were distributed, and there's 156 distinct core funded programs across 246 agencies, and then that 400 number I mentioned earlier, if you're keeping track, was the number of sites that those agencies are operating in. So how do we break this out? How do we think about it? I'm going to talk about things in the infrastructure category: prevention, treatment, and then recovery. I start with the infrastructure because it definitely gets me the most excited, which maybe is a little nerdy of me, but I just think it's so important that we start with what is the foundation of all of these other services. And workforce is vital to that. And so training for clinicians and training for non-clinicians is really essential to what we do. And so I wanted to plug quickly a resource that's out there. It's called the Opioid Response Network, or ORN. In the PowerPoint that you have, you'll be able to click on that and it'll take you directly to that link. This is remarkable. It's free technical assistance to anyone in the state that wants to receive training, one-on-one support, consultation, and it works so easily. You send a little email in this online form that says, this is my name, this is my organization, here's what I want to know. They set up a call, 15 minutes, you describe what you need. They search the state and then the country and find who you need to answer this question. We've had people from California Bridge Clinic flown to Kentucky to provide a training. I can't even, I'd take up too much time if I gave you all of the examples, but it's all free, like truly free. And that's all supported by SAMHSA. So I'd encourage you to check that out. Data waiver trainings are, of course, so important, right? We need data waiver prescribers to be able to provide that access to life-saving buprenorphine or Suboxone treatment. And so helping providers get trained. There's free resources out there too, but we work really hard to link folks with them. NAR certification. So NAR stands for the National Alliance of Recovery Residences. And that is a national organization that has created some quality standards for recovery housing. So important. And so Kentucky has adopted NAR and now certifies houses to that standard so that we can have some confidence when we're referring to someone to recovery housing, that we know that they're going to a safe, clean environment that respects individuals and is going to be the right environment for recovery. And so we're excited to continue to grow that program. We're working on a statewide anti-stigma campaign. I'm really excited. I guess this is the first time I've said it publicly, that the name of the campaign will be Unshame. And it is just going to be intensively focused on discussing stigma and removing stigma. If you're at all interested in participating in the anti-stigma campaign, we have a community group or a kind of a community portal where people can log in, join trainings. If you are an individual that wants to share your story or be part of that campaign, they're collecting stories. It's just going to be, it's really exciting. So more to come there. And then I'll underline again, equity in our infrastructure work. We, when we contract with partners, we require them to disaggregate their data by race and start to look at any inequities that might be arising. And we require them to engage in at least 2 data-driven anti-racism activities. This is really exciting. This is not the normal stuff that you would have expected state government to be engaged in. And we really want others to think about how they can create expectations of their partners to engage in this work. And I won't go through all of them. You'll see there's just so many. In the prevention and harm reduction space, prevention is a big category, right? And so we try to do a lot in it. Primary prevention, school-based and after-school-based, secondary prevention, and then of course, tertiary prevention or harm reduction. All of those are included here. And so I'm going to go through a few of them. I'm going to have to sneak a peek at my slides and see if I gave them to myself or I did not. Okay. One of them is our early childhood consultant services. And so we've placed an early childhood consultant in all of the 14 community mental health centers. And their full-time job is to provide free training to parents and organizations on parenting skills, parent-child bonding, healthy attachment. They have like a nice combination of direct clinical services or direct consultation that they provide, and they can also work with organizations. If you go to the CORE's website, which is core.ky.gov, there's a nice flyer for the early childhood services on the website and a contact person there. Gosh, so much fentanyl test strip distribution. This is exciting. We've only been able to do this in the past 6 months because SAMHSA finally said we could use our money in that way. But getting out those resources so people can test their drugs and have the ability to make decisions about safer use.
So Dr. Marks, we had a question. Can you send us the link for the Unshame project so we could find that?
It's not, we don't have the website yet. That's how new it is. But
Okay.
Once it's out there, I'll get it to you.
Okay, so when she shares it with us, you all, we'll share it through the scope resource page. That'd be terrific. Thank you.
Perfect. In the prevention space as well, I would be remiss if I didn't just plug how important naloxone is in getting it in the hands of everyone. Just everyone at this point is basically the target. But it's important to know that Medicaid covers Narcan. I think a lot of people don't realize this. And so Medicaid actually will cover a free 2-dose unit of Narcan for beneficiaries every 30 days. And so while we are working to provide a lot of free Narcan, know that going to a pharmacy, there's a single standing order that should be able to help people, even if they don't have a prescription, access this. Know that there is funding out there for that. And then also just the importance of syringe service programs and their expansion. This is a lot on a slide, but really it's kind of driving home 2 points. First is that remarkably, there are 81 operating syringe service programs in Kentucky, which is more than any other state, which is something to both be sad that it had to be, but really proud of at the same time. And that is overlaid on showing us where the 54 Kentucky counties are that are most vulnerable for an HIV outbreak. And so we kind of just put those two together, but CORE has put a significant amount of fund at the SSPs, the syringe service programs, to expand their capacity for services. And then quick plug for the Kentucky statewide opioid stewardship initiative. This is operated by the Kentucky Hospital Association. They have commitments from 120 of 127 hospitals for opioid stewardship, and they're working with the hospital partners to improve safe opioid prescribing and non-opioid pain management. I said 120, 112, I apologize. All right, in the treatment space, so much going on here as well, as you can imagine, but a couple that I'm speeding up. I'm seeing my time pass just a little bit, but I would have to start with saying we know that research supports the evidence base for medications for opioid use disorder. Previously referred to as MAT, we now use the term medications for opioid use disorder, again, to reduce and remove that stigma around the medication that it is. The evidence is clear. MOUD reduces opioid use, its craving, return to use, risk of overdose and mortality, recidivism, infectious disease transmission. It's just the gold standard that we have to ensure there is access for. And then we know it improves treatment retention and, importantly, the opportunity for choice and collaboration in the recovery process. And so all of the treatment programs that we fund have to provide access to MOUD services. And one of the ways that we're doing that, and we're hoping to see grow, is through the bridge clinic model. And what this looks like is the collaboration of emergency departments or hospitals in general with their community partners to begin treatment in the hospital. And so when folks come in with an overdose, historically what's happened is they're treated for the acute experience of an overdose and they're sent home at best with a piece of paper with numbers on it. And we know that doesn't work. We know that individuals who have experienced an overdose are so vulnerable for their next overdose. We know that they're in an active state of withdrawal, and that if we don't treat the withdrawal as a medical emergency, because it is, that we're failing as a medical community. And so the bridge clinic model looks like this. If someone comes in, we're going to screen for opioid use disorder. We're going to have a peer support specialist on site that can come meet and engage, really help to create a relationship, a sense of shared experience, and create opportunities for choice and discussion around services. Maybe harm reduction is what the individual is interested in, maybe going to a mutual aid meeting. And for some folks, they might be willing to try a dose of buprenorphine to treat their withdrawal. And so the hospital's ability to provide that buprenorphine, treat that withdrawal on site, and then get them connected to the level of care that they need next. And if they can't get in the next day somewhere, maybe they need to come back to the hospital for one more day. They're not going to leave anyone behind. And so that's the model we're working to establish. And we are really hoping to see this grow, but it's been pretty amazing to see the work that's been done so far. Quick response teams. These are important because this is really, as I said earlier, critical to reaching people in the community. And so this is assertive outreach to individuals that have survived an overdose, to their families, to individuals that are just vulnerable for that overdose. And so this just, I don't know, I like to add little maps so that we can look at something while we talk, but demonstrates where our QRT teams are right now. These individuals, these teams are amazing. They're comprised of whatever the community needs. So oftentimes it's peer support, a first responder. It may or may not include law enforcement based on the comfort with community. And they show up and say, hey, how can we help? It's non-confrontational, it's non-judgmental, it's an opportunity to provide resources. A lot of times it just means they're going to come back to your house a few times in a row until they gain some trust, but they could leave Narcan, they could talk to a family member. There's so much that can be done. Opioid use disorder treatment for child welfare involved families. So DCBS has been really great partners in expanding some of their evidence-based models. I left the links in here so you could look at them yourself, but these are different models that either reduce the caseload of child welfare workers, do in-reach into the home, or co-locate assessors into child welfare offices so that people can get pre-treatment assessment and case management while they're in a DCBS office. And then the last step in this is recovery capital. And so recovery capital, I don't know if you're familiar with the term, but it really kind of tries to encompass the totality of resources that a person has to find and maintain their recovery. And these are the things that we know often stand in the way of treatment access or long-term recovery. And it's stable housing, it's food, it is security, it is employment, it is connection with others. And so it's really exciting that SAMHSA has allowed us to fund many of these activities through the grant, kind of very non-traditional from what we had previously seen from SAMHSA. And so just a few of these that I wanted to highlight. The first is recovery residences. So we do fund a lot of recovery housing and building of new recovery houses across the state. This slide tries to unpack recovery housing. It's not just one thing. I think if you've tried to work with recovery housing or been in recovery housing yourself, you realize that it can look very different. And so we can go from a level 1 peer-run Oxford house all the way up to residential treatment. But what we think is really important is that we grow kind of level 2 and level 3. So these kind of semi-monitored or supervised levels. We amazingly have 100 Oxford houses in the state and are continuing to grow those. But we really lack the volume of level 2 and level 3 houses that we need. So big push there. And of course, you see the National Alliance of Recovery Residency NAR quality standards. Recovery community centers. This is just the epicenter of compassion and hope and innovation and the front lines of this work. And so you can see we funded quite a number of recovery community centers across the state. They all look so different, and I think it really kind of beautifully reflects their capacity. We see mobile recovery community centers popping up. These are community-based, non-clinical physical spaces that people can come obtain peer support. They can get mutual aid, connection, training. A lot of them provide opportunities for getting on a computer and job applications. Endless, really, all the things that they do. So grateful for our recovery community centers. And then access to recovery. I've got 2 more slides for you. This one talks again about that idea that there are some very essential basic needs and tenets that we all have to have in order to engage in treatment or to sustain our recovery, and housing and transportation and childcare are essential to that. And so this program will pay for a lot of those recovery supports that aren't covered by Medicaid, and there's really no other payer source for. We're really excited to partner with alternative sentencing workers in providing access to recovery funds to individuals that are going through the alternative sentencing program. It allows them the opportunity to be diverted from jail and to receive treatment in the community. And then just a quick plug for employment support. Both the Department of Corrections took 10 of their probation and parole officers and said, how about your full-time job is to help people get jobs? And that's been a remarkably exciting program to see. And then the Strategic Initiative for Transformational Employment, it's a mouthful, but we really wanted to move away from second chance employment. We think that people, first of all, they can have as many chances as they want, if you will, and it's not really a chance, it's a transformation. And so helping both individuals get the job training they need, but also teaching employers how to become places where people in recovery can thrive, where people that need treatment can go to treatment and come back to their jobs. And so kind of transforming both at the same time. And with that, I'll just conclude by, we're together, we're stronger than opioids. I hope that you've seen hope through this. I know that you've seen the need and the urgency through the data, and the contact information I'm sure is in numerous places at this point, but stop there and take any questions you might have.
Was amazing, Dr. Marks. And I encourage anyone that has a question, if you want to unmute and ask at this point, you are welcome to do that. A lot of information to absorb, and we'll process it in the small groups as well. But I want to give you that chance to ask her questions directly.
Well, I just have a comment. My son is a musician, and he had a friend overdose and die last fall. So I told him I was coming to this, and he said, "Ask him how I want Narcan in my car, and I want to be able to have 2 friends that will carry it too." And so I said, "Okay, I'll check it out." So you started talking about it, and I was like, "Oh, good, this will be great. I'm going to look up how he could do this." And I've been I got distracted for the last 5 minutes going round and round in circles to try to find it, so we just need to make it easier for people that want to help, right?
Mhm.
That's what I should be good at tracking that down, but boy, I couldn't figure it out. I will continue to look, but somebody else who has, who wants to carry it in their car for friends or whatever might not have the persistence to track it down.
I agree. A couple of things. Oh, I see a comment that I can't read at the moment, but we're working on doing a centralized distribution website where folks can go on and find that more easily. I would encourage, as a first step, is to go to your pharmacist and ask for it. Hopefully there's a standing order. I will throw a link in the chat. If none of those work, we do have a mailing program for folks that need naloxone. It's through Next Distro. It's run by the Kentucky Harm Reduction Coalition and funded through CORE, and that is certainly an option.
Yeah, I did end up there. It's just it's gonna take a lot of persistence and time to figure it out. Like I think that's a source. It's just tricky. Somebody said in the chat that health department could be a good source. So that's a good idea too.
I was just going to say, so I just partnered up with our local health department and went through a training, and I'm helping with a grant that they have distribute right now. And it's been so eye-opening, and how many people don't. I think I thought everybody had it, and I don't think I realized that the locations that they don't, how much needed it was. What county are you in? Are you close to me? Because I have.
Yes, I'm in Fayette County.
Okay. Okay. I'm in Northern Kentucky. So, I mean, I literally yesterday just picked up more. So that's why I thought if you were close, maybe I could.
Yeah, I'll figure it out. I think it's just more of a reflection of, it shouldn't be extremely difficult. It shouldn't take hours, right?
Right.
You hope.
And I would encourage all of us for our different counties to put, as some of you have here, put a link in the chat any week that you can, or send it to Juliet and I for where people can get Narcan in their county. And we'll make sure everybody gets that information.
And let's also make sure we include the one that's the pharmacies that stock it. That can be helpful as well.
Great. All right. So evidently, Elena, thank you. Fayette County Health Department did some training on Narcan. All right.
Dr. Marks, I have a quick question for you about I believe it was the Bridge program. I saw a lot of the major hospitals in Kentucky, and I know that right now people are really struggling with finding beds, even for patients, not afflicted with COVID, just because of the COVID numbers. And I heard you talking about a lot of these interventions are in the ERs. So I was just wondering, what kind of effect that you've seen from COVID, and maybe what you expect in the future from that.
Yeah, wow. I mean, COVID has just been devastating for us. What we initially saw is that people stopped going to the ERs, not just for opioid related issues, but categorically. They weren't getting as much medical care through there. And so we saw a huge downturn in folks utilizing that. In terms of hospital utilization, our utilization, it has normalized and kind of returned to a stable point, but it's really, and many treatment providers are now doing kind of dual telehealth and in-person services, which has been really wonderful to see that capacity grow. And I absolutely expect and hope that it'll stay in place. I've lost track of your question a little bit, so I'm going to apologize for that and maybe ask you to ask it of me one more time. Yeah, I'm gone.
Yeah, I was only wondering if, maybe they had planned to change the way that those interventions were being performed just because of the bed issue. Central Baptist, UK, those big hospitals, people truly just haven't been able to get in.
Yeah, so a lot of times the bridge clinic model itself is that folks come into the ED, they're probably discharged that same day. And if they can get them home and on buprenorphine, that's ideal, or they're referred to a residential level of care that same day. But that inpatient consultation service is really important because a lot of people do end up on the floors, and a lot of people, the opioid use disorder isn't discovered until they've been in the hospital for a few days and they're starting to demonstrate opioid withdrawal. I haven't personally heard about, not that it doesn't exist, but about not being able to get into the hospital for OUD treatment, but certainly it has to have occurred. I mean, we know that hospitals were completely tapped out and continue to be stretched.
Good question.
Thank you.
Other questions of Dr. Marks?
We're a little bit behind, but I did want to ask about diversity, equity, inclusion, which you mentioned several times. And it's a big passion of mine. And I know that workshops with people don't really make a change. I mean, studies show that. So policy makes a change. So what are the things that are happening in those areas where you were sharing, which I'm hopeful just by hearing you say that, but what are they doing to ensure that something changes?
Yeah, I think that you're absolutely correct. One of the first things that I know that the cabinet is doing is being able to monitor it so that they can demonstrate that the change is happening. And so this is a really small example, but Medicaid for a long time was not requiring that race or ethnicity being included in the data set at collection. And so by creating a policy and implementation support to require the collection of that, we can now say, this is the disparity right here. This is how we're tracking it. And so that's a concrete example of kind of just preparing for that policy change. I think that in the policy space for us, in opioids specifically, it's really like we spend a lot of time in the justice related space. So are there policies that say if you have felony X, then you are going to be incarcerated and you're not eligible for the alternative sentencing worker program, which would allow you to receive your treatment in the community? We know that that disproportionately sends Black Kentuckians to prison and white Kentuckians into the community. Those are the type of policies that the Restore initiative is specifically looking at addressing, figuring out which are state policies, which are federal policies. But I think that's probably the closest example of a policy change. Also just investing, right? Investing in BIPOC-led organizations it's not a policy with a capital P, but it's a policy with a lowercase p that says we're going to ensure that our resources go to the people that know what is needed of their community. And so I think that's another example of the way the cabinet's shifting, or at least we're working to shift the funds.
Important question, Tanya. And this is our one chance to talk to Dr. Marks. So, I don't mind that we're going till 5 o'clock. I told her we might do that. And so this is really rich information. And I want to give you all one last chance if you have any questions for her.
And I'll say, Tanya, if there are specific things that you're thinking about, I'd be really open, really interested in having additional conversations and learning more from you.
I would love that. I'll send you an email.
Perfect.
Tanya is one of our community organizers. You will hear from her, no doubt.
Hi, I'm Bridget with Voices of Hope. Well, one of the problems I find daily is with helping participants with Medicare. It seems more difficult to get participants with Medicare help than it does Medicaid.
Mm-hmm. Yeah, that's a full sentence. I completely agree. Yeah.
So are there going to be any changes? Are there other ways around it, or?
Yeah. So the Medicare policies are federally mandated. So the state is pretty limited in what they can do. But what we can do is build in additional support and infrastructure. For example, CORE funds the treatment access program. So if an individual needs a residential level of care and they have Medicare, which does not pay for residential treatment, don't get me started, the treatment access program can pay for that. And so there's about 45 different programs across the state that will take core funding to pay for up to 30 days of residential, 6 months of IOP, and 2 months of room and board to extend services. It's only for folks with opioid use disorder, and you have to be at 150% or below the federal poverty level, but that's about it in terms of criteria.
Thank you.
You're welcome. It's really important, though. It's so important that we get this changed.
Thank you all for your questions. Thank you, Dr. Marks, for your time with this group. This recording will be posted on the website, so you guys can go back and look at it, as well as her PowerPoint. And I will check and make sure that the PDF we sent you of the PowerPoint has the links that work. And if not, we'll make sure you have those links. What we will do now, I'm going to share my screen and we're going to go to the breakout groups, and I'll explain to you how this will work. And Dr. Marks, thank you once again for so much for getting us started in such a great way.
Caroline, just double checking. Should I stop recording now?
Yeah, that would be a good idea.
Okay, thanks.
Thank you. Thanks, Brandon.